Hey, folks, welcome to EMS Challenge. We are live in Irondale today. Thanks, Irondale, for hosting us. Super appreciate it. Still got plenty of space. And then don't forget, this afternoon we have our new EMS fellows, EM residents, and then we have the pediatric coaches sim team coming out. So we're going to do cardiac arrest training, go through some probably some mega codes, and then we're going to do the pediatric sim stuff. So a great day today. Couple of updates. Remember, new protocols went into effect August 1st. If you as an agency in this region have not done your protocol update, you need to get that done, turn in the state. Okay, very good. A lot of echoes. This is great. Yeah. Yeah, I hear worse in my head. Yeah, right. I'm not going to tell you what I hear in my head. That's privilege. It's HIPAA, right? Oh, my God. Um, The other thing, we have our protocol update on the YouTube channel. Feel free to use that. That is not all inclusive. So if that's all that you used, please remember there's more to it than we could put in 2 hours. So review that. If you have questions about the state protocols, reach out to your regional office or to the state medical officer. One of those two places is a great place. Updates. We'll be at Brim's in 2 weeks doing EMS challenge. September 11th, the afternoon, we're doing an EMS cadaver lab. It's free. It's on Eventbrite right now. We'll be there the 11th, the 12th, which is a Friday, and then I'm actually going to be there Saturday as well. And it's open to anybody that is free. Please sign up. If you're an agency that wants to send on-duty crews there, shoot me a text or an email. We can work you in. Don't use Eventbrite. And that way I can make sure to prioritize the folks that are on duty. Okay. So Dr. Cohn, one of our senior residents, we'll get started. Thank you very much.
Cool. I think my microphone is on, hopefully. Awesome. Cool. I'm Miller. I'm one of the second-year residents at UAB. So I am doing abdominal emergencies and high-risk pathologies. And unfortunately, the abdomen has a lot of things in it. So this won't be like an incredibly comprehensive review, but hopefully we'll be able to get enough stuff done in the next hour or so. Ferg made me put this in. I have no one's paying me to do this. Ferg made me do it. But otherwise, we're getting ready to start. So this is kind of just a brief overview of what we're going to do. As far as going over abdominal pain, it's a common complaint. I'm sure y'all see it every single day, but it can be fairly high risk. And then talk about at least some pre-hospital triage, some early identification of like acute pathologies, and then appropriate management and transport. Then a couple objectives. We're going to try to go over just briefly some abdominal anatomy and kind of the systematic approach that we would use in the emergency department when we're like going through abdominal complaints to try to figure out, kind of narrow down our differential a little bit. Recognize some red flags of abdominal emergencies, and then discuss some pre-hospital interventions, and then kind of go over, once y'all have handed them off, like, what do we do after that? Kind of what do we do in the emergency department? What's our disposition? All that sort of stuff. But at any point, kind of like Ferg said, if anyone has any questions along the way, just kind of stop me and we'll talk about whatever we need to. So just a little bit of epidemiology just to start off with. Abdominal pain accounts for about 5 to 10% of all ED visits in the United States. Essentially, it's one of our most high volume complaints. I don't think I go a single shift without seeing at least a couple of abdominal pains. And there's not really a lot of data on it, but you can extrapolate from that of course it's something that y'all see essentially every single day. So it's something we all see a fair amount. And then about 15 to 20% of all these complaints require some sort of intervention. Doesn't necessarily always mean surgery, but some sort of intervention. Most commonly, the etiologies are fairly non-emergent, whether it be like gastroenteritis, non-specific abdominal pain, or biliary disease. But then again, when they do have a pretty emergent complaint, they can get very sick very quickly. So it's important to recognize some early recognition and intervention. And then we'll go over this a little bit later as well, but just some high-risk populations, just to go ahead and get that out of the way. Is anyone that's elderly, they can kind of hide a bunch of badness in their abdomen, and you may not know. A lot of our attendings say that older bellies lie as far as their exam and everything, so it's just always something to keep in the back of your mind. Anyone that's immunocompromised for any reason can also similarly hide something bad, and their exam may not necessarily show it. Pregnant patients, not only do they have pregnancy, but it also shifts their abdominal anatomy, can make things a little bit different as well. Then any patient with substance use disorder, they're at a high risk for like bloodstream infections and kind of seed abscesses and all that sort of stuff as well. So just a general approach to abdominal pain, like especially acute abdominal pain. And I feel like, and I don't necessarily have a pointer on here, but you see like several ticks on there. Y'all kind of fall in between this second and this third tick as far as all the work that y'all do prior to them getting to us, right? So it's, trying to get an adequate history and exam, trying to figure out, what sort of medical history they have that might kind of give you clues as to what's going on. And then, the proper analgesic use. And within that, I think also, like any antiemetics, fluids, blood, anything like that. So, a lot of times by the time that patients get to us, y'all have already done 50 to 60% of our job as far as like getting them stabilized, getting them treated so that we can kind of figure out what's going on and go from there. And, essentially we'll try to take it down the line. And again, this is just something to kind of think about, not necessarily the imaging and the surgical consultation part, but just trying to eliminate biases whenever we're trying to avoid any misdiagnosis whenever we're looking at these abdominal pain patients. So briefly, this is just kind of an overview as how a lot of us approach abdominal pain as far as when we're looking at patients. There's a lot of organs in your abdomen, and unfortunately I don't have a pointer for everyone to see, but I would say you kind of take both of these charts and kind of combine them together. So obviously everyone uses like right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. But then along with that, a lot of us will also use like the epigastric region that's in the left graphic, and on the umbilical region is also something that we'll look at as far as like, what sort of organs or what sort of pathologies that we might be looking at. Because as you can see, different quadrants have different things as far as like, right upper quadrant, you got liver, gallbladder, all that kind of stuff. Left upper quadrant is more so your stomach. But then anything, sometimes these can be like diffuse complaints as well. And so it just helps us kind of try to narrow down our differential just a little bit. So this is a systematic approach that I feel like almost all of us in the emergency department use when we're trying to look at abdominal pain. And then this is just a graphic of referred pain. Unfortunately, your nerves kind of run everywhere, and so you can get a bunch of weird referred pain. You can get shoulder pain from like any irritation of the diaphragm. And again, we're not going to go over all these, but your appendix can kind of go all throughout your like right lower quadrant. You can have, ovarian pathology that's in like your umbilical region. Your colon can kind of radiate diffusely, and then you can even have pain in your back from like liver and gallbladder disease, heart disease, anything like that. So again, just kind of something to keep note of, as well as you can have referred pain that can kind of go all throughout your body as well. So just a little bit of like pre-hospital perspective as far as what do we need to know, or like what are the big things that really help us out a lot. Now, a lot of times, obviously, y'all give us a lot of this stuff anyways, but just something to always remind us of. I think, everyone knows vital signs are, one of the main priorities that we need to know as far as like, are they in shock? Are we concerned that they may be developing shock? Or, the tachycardic, are they hypotensive, anything like that, and then the reasons why. A good physical exam, that can be especially helpful, especially if y'all come in and, you can tell me like they're peritonitic, or they've got like rebound or guarding in the right lower quadrant or anything like that. It helps me to already kind of frame in mind like what I'm going to do for my exam, and then what sort of interventions we order, especially if you're bringing someone in that's acutely ill and is very sick, and we don't necessarily have time to go and comb through all their history and everything like that. Anything that y'all can give us on the way kind of helps us tailor like what meds we're going to order, and just kind of facilitates faster care. Past medical history, obviously, diabetes, hypertension, AFib, previous surgeries, anything like that can be especially helpful. Immunosuppression, and we'll kind of talk about that later as we go through some cases. And then onset and circumstances surrounding their pain is also really important. Is this chronic? Has this been going on for days? Did this happen acutely and all of a sudden they're in severe pain? All that kind of changes our differential and kind of things that we might be looking at. Any home medications, again, immunosuppressives, are they any diabetes regimen, any recent antibiotics, and of course any blood thinners as well, especially if we're thinking they're in some sort of hemorrhagic shock. Associated symptoms, more so like pretty severe things, like did they have like syncope with it? Are they febrile? That kind of thing. Most patients with abdominal pain are going to have some sort of nausea and vomiting, much more so like some of those other less common associated symptoms that we kind of worry about. And then any interventions you gave en route, of course, any medications, fluids, antiemetics, blood, etc., that you might give. And I wanted to kind of stop and because I've had this happen a couple times, is there's multiple studies that show that you should not delay giving any analgesics to try to confound someone's exam. Especially in these patients that are acutely ill, any sort of analgesia, any sort of comfort we can give them is important, and it's not going to confound our exam necessarily, especially if they have some sort of pretty significant pathology. Our exam is still going to show that. So don't be worried about giving them pain medication en route and think that you're going to screw up our exam, because I've had that happen a couple of times. And then any pertinent physical exam findings, obviously, kind of like we talked about, are they unstable? But more so, kind of like we were talking about earlier, is where are they tender on the abdomen? Is it right upper quadrant, left upper quadrant, whatever it is, that might help us to kind of narrow down our differential. Does their pain radiate? Again, and we'll kind of go over this after some cases, but certain pathologies classically have radiating pain, especially to the back, and that can be like a heads up, that there might be something pretty serious going on. Are they peritonitic? And peritonitis is not, like you press on their belly and they just say that it hurts. It's, you can barely touch their abdomen because they're so tender. Their abdomen is rigid, they're guarding. all that sort of stuff. There's been several times even in the ED where I've had a patient that's, frankly peritonitic, and I'll go ahead and call surgery even before I get labs. And a lot of times they'll come down if they think the exam is impressive enough, they may even take them straight to surgery, just because, an exam that concerning just, in itself says there's some sort of pathology that needs to be addressed quickly. Is there a palpable mass, especially in the setting of something like a AAA or something like that? If you can palpate a mass, and especially if it's something that's pulsatile, meaning, it's pulsing right back at you, then that's something that needs to be addressed sooner rather than later. And then any symptoms of GI bleed, whether it be upper or lower. Obviously, if someone's vomiting blood, that's not, of course, you're going to come in and say that. But, even if someone has a history or they're saying that they've been having like dark stools or anything like that, it can be something that's helpful to us. So just some key red flags kind of when you're looking. And again, a lot of this stuff kind of like rolls into each other. But again, hypotension, tachycardia, signs of shock, any peritoneal signs they might have, any signs of GI bleeding, syncope and altered mental status, especially in the setting of abdominal pain, can be really worrisome. Especially, if someone syncopizes and all of a sudden they have like acute abdominal pain, you might be worried about dissection, something like that. And so that's always something that's important to know. And then just a couple of dangerous pitfalls, something that's, even easy for all of us to miss, even in the emergency department, is if they're having pain out of proportion to exam. I think a lot of times it's kind of difficult to say, or easy to say rather, that, they're actually not that sick. You press on their belly and they're not in that much pain. They're just kind of writhing around when you're looking at them. But, that can be a sign of something like mesenteric ischemia or something like that, especially in your elderly patients with AFib, something to always take into account. And then again, stable vital signs masking serious pathology. So just because they're stable doesn't mean that, they're not going to be unstable in the next few minutes or something like that. So especially if you feel like someone has a pretty significant complaint, it's always important to, especially when you're transporting them, try to keep, update their vital signs as much as you can on the way. And again, we kind of went over this already, but this is kind of the approach that we take in the emergency department as far as looking at our abdominal quadrants like we talked about earlier and thinking about what associated organs are there. Timing again, acute versus chronic. Pain character. So that's something that helps us a lot, whether it's, colicky, meaning that it's somewhat intermittent. That's something that most people would describe as like a kidney stone essentially is like colicky pain, because it's like, comes and goes. Sharp pain, any sort of radiating pain, anything like that. Again, associated symptoms, more so like your fever, hematemesis, melena, that kind of stuff. Again, vital signs and past medical history is the way that we look at an ED. And it is not an exhaustive list by any means. This is just me sitting down and over a couple minutes just thinking of like can't miss diagnoses for the abdomen. There's more than this, but again, this is more so just to impress upon everybody that there's a lot of stuff that can go wrong in the belly, unfortunately. And so you kind of have to be thinking of everything, and trying to use a systematic approach can help you whittle this down a little bit. But again, there's just a lot of stuff that can be going wrong. So don't try not to anchor on one thing, kind of as you're like evaluating these patients. And so this is how we're going to break down cases. And before I do the cases, I tried to fly through that stuff pretty quickly just because we have a lot of slides and stuff to get to. Does anyone have any questions or anything thus far about anything we've talked about? Very good. And so this is kind of how we're going to break down these cases as far as like mostly looking at abdominal pain and things that can manifest from abdominal pain. So we're going to start with just like a case of like diffuse abdominal pain, then move to like right upper quadrant, epigastric, left upper quadrant, and essentially work our way through those quadrants that we talked about earlier and kind of talk through one specific pathology and then just briefly note a couple other pathologies that could be going on in that compartment. Don't worry, I'll read the cases. So we have a 50-year-old female called out for diffuse abdominal pain. It began 24 hours prior and has been worsening since it began. She has some associated nausea and vomiting. She is unable to tolerate PO, and she has some constipation as well. She has a history of hypertension, diabetes, previous cholecystectomy and appendectomy, and hysterectomy. Vital signs are fairly stable. She's a little bit tachycardic, but otherwise she looks fairly well. And then on your exam, she's uncomfortable. She's actively vomiting. She has diffuse abdominal tenderness to palpation without peritonitis and without focal tenderness. So just from that little blurb right there, any sort of things you might be worried about just from the onset, as far as any sort of like pathologies. SPO, that's a good one. And again, I know it's vague, but anything else? Do what now? Yeah, acute colitis, gastroenteritis. Doesn't have to always be like something super acute. It's not necessarily gallbladder disease or appendix because she has those taken out. Anything diffuse in the abdomen, you could think really anything. It could be anything at this point. But for this one, at least, small bowel obstruction. So big things that give it away. And well, first, what is a small bowel obstruction? It's either a partial or complete blockage of the small and large intestine. And so what you're seeing here, actually, this is an x-ray. We don't really do a ton of x-rays anymore when looking at abdominal pathology, but this is one where it can help you out a lot. And it's kind of tough to see, but if you can see, like within their bowel itself, you have a bunch of what we call like air fluid levels where it's like very demarcated like throughout the bowel. So that's a sign that there's possible obstruction going on. And with small bowel obstructions, the main cause, the cause that's especially most prominent in like the U.S. is adhesion. So essentially, after these patients have some sort of surgery, the irritation from the surgery like creates adhesions and it causes these small bowel obstructions. But it can be caused by hernias, malignancy, intussusception, especially in pediatrics, foreign bodies, trauma, gallstone, even gallstone ileus. And again, kind of like this lady had, they'll kind of present with like diffuse abdominal pain, nausea, vomiting. They'll have some abdominal distension. That's another important physical exam finding. I don't think I listed. If their abdomen is particularly distended, so that's always something to note. And then they will typically have an inability to pass any stool or flatus, and they'll be dehydrated. They won't want to eat, and every time they eat, they'll essentially vomit every time. These patients can be very, very uncomfortable. They can get very sick very quickly, whether it be dehydration, electrolyte abnormalities, kind of a whole host of things can happen with these patients. So prior to arrival at us, especially if this is something that you suspect, I think one of the biggest things is just appropriate fluid resuscitation with like IV fluids. That's something we do. It's a mainstay for SBO in the hospital. Also, if you are suspecting like an SBO, try to keep them NPO. Try not to give them anything by mouth. That's a big thing for us. And then, make sure that their nausea and pain is treated appropriately. And then if there's any sort of hemodynamic instability, obviously that's something that we want to know, and it's something that, you may want to transport them more rapidly or at least get them to a hospital with surgical capabilities faster. And so once they get to the emergency department, kind of once y'all handed us off, this is our normal, like typical workup for these patients. Again, labs, getting a CBC, especially looking for like a leukocytosis or something, checking their electrolytes. If we think that they're very ill or there might be some sort of bowel ischemia, we'll get a lactic. That kind of helps us risk stratify and see if there's any sort of bowel ischemia or sepsis or anything like that going on associated with their SBO. And then imaging, again, we don't really get like abdominal x-ray series anymore. No, a lot of times we're getting a CT of their abdomen pelvis with contrast. And again, kind of like what the arrow is showing is these like air fluid levels and signs of distension in their abdomen consistent with like an SBO. So it's like a CT scan slice of their abdomen. And again, management in the emergency department, it's going to be volume resuscitation. All of these patients are going to get a nasogastric tube just to help decompress their bowel. And then pain control, and then correction of any underlying electrolyte abnormalities. And then sometimes we'll give antibiotics if we're concerned for sepsis, but not routinely. And then obviously they're getting a surgical consult, and we'll kind of go from there. And I would say, and that 75% is from a paper that I read as far as like they're amenable to non-operative management. But I would say pretty much every single small bowel obstruction that I've had in the emergency department has been well enough to where we were able to place an NG tube down and admit them for like serial abdominal exams and for the monitoring, but they didn't have to go straight to surgery. So very rarely, I think these days, are these patients going straight to surgery. But a lot of times we'll have the surgeons come down and see them and kind of weigh in. And again, this is just not an exhaustive list, but just some other things to also be thinking about with diffuse abdominal pain, bowel obstruction, volvulus, which is when the bowel actually twists upon itself. You can have bowel perforation, which can cause diffuse abdominal pain, DKA. This is not always like a acute like intra-abdominal process as far as like the abdominal organs. It can be metabolic, it can be vascular, it can be all sorts of things. So DKA, they can have a hernia, whether it's like an incarcerated or strangulated hernia, mesenteric ischemia, spontaneous bacterial peritonitis, especially in like your liver failure patients, is something to be on the lookout for. AAA, and then aortic dissection as well. So any questions about that one at all?
So the ultrasound you said was non-standard of care at this time.
Yes, sir.
So what's the value or utility of ultrasound? Is this something, small bowel obstruction, something that most people using ultrasound can see?
No, not really. All the data they've done, it's pretty operator dependent, whether you can actually do it or not. And even then, I don't think it can't give you a definitive diagnosis. If anything, it's more like a diagnostic tool to just kind of help build your gestalt as far as like if you think this is an SBO or not. But again, the standard of care is a CT scan as far as any sort of imaging you might get. Down the line, as ultrasound gets better and as we as clinicians get better at ultrasound, maybe, but at this point, it's more so just for your own like physical. It's essentially just like adding to your physical exam as far as like looking and thinking that might be a pathology that's going on, sort of thing.
Yeah, the key thing is you can look for other things that could cause belly pain there. So that's the benefit that I see for the ultrasound for this.
Mm-hmm.
And remember, when you think about SBO, one of the things that they're not having bowel movements, they're not moving stool, right? This is not the same thing as constipation, just to be clear. A bowel obstruction is important because the bowel obstruction, a lot of times that colon will get ischemic and then perforate. And then everything that lives in your colon goes into your peritoneal cavity, which is bad. People die from that. So most of these folks, like you said, can be treated with the NG tube, observation, rehydration, check the problem out. But some of these folks get sick pretty quick and can die from this. So that's why this is important. Right.
Okay, epigastric pain. Next on the list. So this is a 35-year-old male called out for epigastric abdominal pain. It began earlier this morning. It's been constant, radiates to his back, some associated nausea and vomiting, along with some inability to tolerate PO. Pain is worse with eating. He has a history of tobacco abuse, alcohol use disorder, diabetes, and cholelithiasis. Vitals, he's a little bit hypertensive, a little bit tachycardic, but otherwise his vitals are fairly stable. He has some tenderness palpation over his epigastric region with some mild guarding. He has no obvious mass or hernia, and he has some ecchymosis or bruising over his periumbilical region. And when you look at him, this is kind of what you see. And specifically, it's called Cullen's sign. So, any differentials for this guy? Blood in the abdomen, sure. Cholecystitis, sure.
Auburn fan?
Auburn fan, probably. What? Cirrhosis, could be. Yeah, definitely. Especially with a history of alcohol use. And so looking at him, this guy actually has pancreatitis. So the big thing that tells you that this is pancreatitis, or at least might clue you in that it's pancreatitis for this guy is, epigastric pain radiating to the back. He's got a history of alcohol use disorder. I think cirrhosis and pancreatitis are probably on the top of your differentials there. So your pancreas, it kind of goes throughout your kind of like most of your upper abdomen, but it kind of sits right there in your epigastric region. And so for us, at least, I think almost everyone that comes in with any sort of epigastric tenderness, that's one of the first things that our mind's going to go to. It's acute inflammation of your pancreas and your surrounding tissues. And you'll see there, the gallbladder's kind of around there as well. You've got some bile, your duodenum's kind of around there as well. There's several different causes for pancreatitis. Gallstones worldwide is the most common cause. Essentially, a gallstone will come in and will plug the essentially where the pancreas drains out into your biliary system and out into your duodenum, and that backup of pancreatic enzymes can cause inflammation in your pancreas. But then again, alcohol use, it's not uncommon to get these after an ERCP. So just something to keep in mind if you have a patient that calls for abdominal pain and they just had some sort of procedure and it's ERCP or something like that, it can cause that. You can have it from drugs, autoimmune disease. You can get it from scorpion stings classically. That's like a thing they'll ask us on our boards all the time. There are scorpion stings that can cause pancreatitis. But clinically, have the pain mostly in their epigastric region. It'll radiate to their back. It typically actually improves when they're leaning forward, helps to take some pressure off their pancreas. Then they'll have some nausea, vomiting, abdominal extension, all that sort of thing. But more severely, if they have really bad pancreatitis is like an acute inflammatory process, and that inflammatory process can cause an inflammatory cascade throughout their whole body. And so they can get what's called ARDS, which is essentially it's acute respiratory distress syndrome, where you get inflammation of your lungs, and so they can have some hypoxemia, they can be tachypnic, and then later on down the line they can actually form pancreatic pseudocysts from repeated inflammation, and those can get infected as well, and they can get septic from those. These patients can be very, very sick. They're normally very, very uncomfortable. They're in a lot of pain. And then so pre-hospital, it's actually, you'll find a lot of this is pretty similar, and it's a lot of times it's essentially going through your ABCs and just making sure we're addressing those first and foremost, right? So for these patients, fluid resuscitation is really, really important. Obviously making sure their pain and nausea is under control. If they are hypoxic, if anyone is really hypoxic, obviously you're going to put them on oxygen, but these patients can be hypoxic from that. And then again, we're just monitoring for any hemodynamic instability, any signs of sepsis, anything like that, any sort of worsening respiratory status. So when they get to the emergency department, one of the big things we're going to do is a lipase. We know lipase is very sensitive for pancreatitis. Almost everyone we're concerned is going to, that has pancreatitis is getting a lipase ordered. CBC, CMP again, LFTs, a lactic if we're concerned for sepsis. And then Epigastric pain can a lot of times be an atypical presentation of like cardiac pathology as well. So any patient with like epigastric pain, especially if they have a history, they're going to get an EKG and a trope as well. And then for pancreatitis, a lot of times, again, the standard imaging is CT abdomen pelvis with contrast. You can do an ultrasound as well. I don't think it's quite as accurate, and so a lot of times we'll do a CT on these folks. And to be able to diagnose pancreatitis, you actually have to have 2 of the following 3 criteria. So they have to have the characteristic abdominal pain and pancreatitis, so epigastric pain that radiates to their back. And then a lipase that's greater than 3 times upper limit normal, and then characteristic findings on CT or ultrasound. And again, I think maybe in some resource-limited places they might use ultrasound more. If someone has a history of pancreatitis and they've had a lot of CT scans, I think an ultrasound is something that might be appropriate. But for a lot of these patients, they're getting a CT scan. The management, especially in the emergency department, if they're fairly well, it's fluid resuscitation. Used to, they would try to actually keep these patients NPO for a time and try to make sure that this inflammation goes down. But now they're actually trying to restart their diet as soon as possible. So as they're able to tolerate food, they try to get them eating as soon as they can. And then, proper analgesia, antiemetics, and then any electrolyte abnormalities they might have. Because a lot of times this pancreatitis is also associated with like other past medical history. And so normally these patients have some sort of electrolyte abnormality that needs to be corrected. And then disposition for these patients. If they're overall well appearing and their symptoms are controlled, especially if this is like a recurrent pancreatitis, if they've had it previously and they otherwise look okay and they're able to eat, a lot of times we can actually send them home with like pain medication and just make sure they hydrate and make sure they follow up closely with their primary care doc. But again, if they're unable to tolerate PO, if they have obvious signs of sepsis, any hemodynamic instability, they're being admitted for pain control and further evaluation. And especially if this is their first bout of pancreatitis, a lot of times we'll admit them as well to kind of figure out why they got it, whether it was a gallstone, if it's alcohol use, all that sort of stuff. But these patients can also get pretty sick pretty quickly. Any questions about that? Cool. And then again, just some more epigastric pain differentials. You can have gallbladder disease, can definitely cause it, like epigastric pain, unfortunately. Gastritis, GERD, peptic ulcer disease, bowel obstruction, MI-ACS, AAA, aortic dissection. You'll find AAA and aortic dissection can essentially cause pain almost anywhere. So they'll be in a lot of these differentials as well. But then again, these aren't exhaustive lists, just a couple other things to think about when you're kind of evaluating these type of patients. All right, right upper quadrant.
Hey, I'm going to throw just one thing, just to remind you, anybody with epigastric pain also gets a 12 lead.
Yeah.
I always think about that. I know he said it, but I always do that. So the other thing is for pancreatitis, a lot of these new diabetic medications, the injectables can do that. So that's a good question to ask your folks. Are you diabetic? Yes or no? Do you take shots? Yes or no? I used to say that if they take shots, you always assumed it was insulin. Now it could be anything, but a lot of these medications cause pancreatitis. Yeah. Just food for thought.
Yeah. All right, right upper quadrant. So 45-year-old female called for worsening abdominal pain. She was originally more intermittent, but it's become more constant severe. It does not radiate, worsen by eating, and she has some associated nausea and vomiting. So has a history of hypertension, diabetes, and GERD. When you get to her initial vitals, she's 100/60, so a little soft. She's tachycardic. Oxygen saturation stable. She is febrile at 101.7, and then on exam she's uncomfortable. She's got some scleral icterus. She's her right upper quadrant is tendon palpation. She has a positive Murphy sign. Do you know what scleral icterus is? So it's essentially just a fancy way of saying she has yellowing of the eye. She has like jaundice, or like her like the whites of her eyes are yellow. And then does anyone know what a Murphy sign is? That's McBurney's point. Yeah. So Murphy sign is when you're pressing on the right upper quadrant, you can ask them to like take a deep breath once you're pressing, and they'll catch their breath. They'll like stop breathing. That's like a positive Murphy sign. So a lot of times, even if they're doing an ultrasound, they'll do like a Murphy sign while they're doing an ultrasound in the hospital too. This is like a good diagnostic, like physical exam tool that we have. So any differentials for this lady? Cystitis, yeah. Sure. Liver failure, hepatitis. Definitely someone that's jaundiced. Again, it can be a whole host of things. But this lady in general, and we'll get to like her actual diagnosis in a second. But yeah, again, right upper quadrant, almost everyone is going to go to like some sort of gallbladder disease first, right? So with this, there's an obstruction of bile flow through the biliary system. It can cause a broad range of symptoms, especially depending on where the actual obstruction is and how bad it is. And there's a spectrum of disease as far as gallbladder disease. It's not just like cholelithiasis, cholecystitis. So you can have like symptomatic cholelithiasis where you've got gallstones, but there's no acute like cholecystitis or inflammation around the gallbladder itself. You've got acute cholecystitis, which is inflammation around the gallbladder. You've got ascending cholangitis, and these patients can be very, very sick, and it's an infection of the biliary tree in the setting of obstruction. Choledocholithiasis, acalculous cholecystitis. There's all sorts of pathology, but the main two that we normally think about and are trying to differentiate between is the acute cholecystitis versus the ascending cholangitis, because those patients can initially present very similarly, but their dispositions are a little bit different, and ascending cholangitis, they can definitely be very, like, they can get much more sick much quicker. And then obviously this is just a gallbladder that's full of stones. There's two types of stones. There's pigment stones and there's like cholesterol stones. Pigment stones are very dark. A lot of times it's from like hemolysis and like blood breakdown. You can get pigment stones, and then cholesterol stones are obviously from like buildup of like cholesterol, essentially causing these stones. And I think honestly the big ones look kind of like cholesterol stones because they're a bit more yellow, but those dark ones are definitely pigment stones. And then again, this is just like a brief like an anatomy of like your biliary tree. You've got your gallbladder and your cystic duct and your common hepatic duct that lead down to your common bile duct. And so any obstruction anywhere along that path can cause these symptoms and can eventually lead to like any sort of cholecystitis or cholangitis. So in differentiating the two, so acute cholecystitis is primarily a blockage of the cystic duct. So that duct that kind of is running down from your gallbladder before your common bile duct. And it can cause like right upper quadrant pain, that positive Murphy sign like we were talking about. It can cause some fever and some nausea and vomiting, but they'll typically be hemodynamically stable and they otherwise look fairly well. I've had a couple acute cholecystitis that were actually fairly sick, but a lot of times, they'll look ill, but they won't be like acutely ill or septic or anything like that. And then you can have ascending cholangitis, which is a step essentially above this acute cholecystitis. And there's a blockage of the biliary tract, and essentially what that blockage does, it allows, so typically it's from the duodenum because that's where your biliary tract drains into. They'll have like an ascending infection of bacteria up until your biliary tree. And so it's typically from like cholestasis, which is essentially just like stasis of this bile. And they'll have what's called Charcot's triad, and like 50% of these patients will have that, and it's fever, jaundice, and right upper quadrant pain. And then on top of that, you can have Reynolds pentad. So it's the fever, jaundice, right upper quadrant pain, but then you can add altered mental status and hypotension onto that, and that's about 5% of the presentations of this ascending cholangitis. And these patients can be very, very sick. And so looking back at this lady, she's got fever, she's got right upper quadrant pain, but then she also has, she's starting at least to get hypotensive, and then she's got some scleral icterus, which we would count as jaundice. So she's more so heading along that like ascending cholangitis route than rather like an acute cholecystitis. So again, both of them can be fairly sick, but this is a lady I'd be pretty concerned about, someone that, but she's probably going to need some sort of intervention sooner rather than later. And so pre-hospital intervention for these folks, again, it's essentially the same thing, is recognizing sick versus not sick, and if they're hemodynamically unstable. And the big thing with that is, make sure we're giving them appropriate fluids, again, pain control and analgesia, and antiemetics, and then, screening for signs of sepsis and shock. And, anything that y'all can do before they get here is obviously going to help us out as far as getting them stabilized. And so then in the emergency department, obviously, normally y'all have already done this for us, but we'll obviously do any sort of rapid correction of any hemodynamic instability if they get to us. And if we're concerned for sepsis, we'll start them on antibiotics. These folks are getting like a CBC, CMP, LFTs to look like liver function. If they're really, really sick, we're going to get blood cultures as well. Each ECG and troponin again. Right upper quadrant pain, especially in like older females, can also present as like a form of like ACS. So a lot of times if you got the time, like a 12 lead on these patients wouldn't be unreasonable either. And then imaging, the gold standard for us is a right upper quadrant ultrasound. And we're looking for a lot of things. We're looking for like dilation of their biliary tract, any sort of inflammation around their actual gallbladder wall, sludge, gallstones. Do they have any fluid around their gallbladder? Is there any air around the gallbladder? All these things that can be really important in like differentiating whether this is like a cholecystitis or like a cholangitis. And in this ultrasound, it's got a lot of stuff in it, and it's just more so to kind of show you what we typically look at when we're trying to get an ultrasound of these patients. And so like you got your liver on top, and then that big circle is your gallbladder, and that's a pretty distended gallbladder. It's got some sludge and gallstones in it. We're also looking at how big the wall is, and And we have certain metrics as far as like how many millimeters the wall is supposed to be, and it's above that, we know there's like information on the wall and all that kind of stuff. So, but that's just like a brief snapshot of what one of these ultrasounds might look like. So for acute cholecystitis, a lot of times these folks are going to be admitted. They're going to get a consult to ACS or acute care surgery, at least at UAB is what we call it. And they'll get like a cholecystectomy. Sometimes if they're really sick, they may like need to be resuscitated first, and then they might get like a cholecystectomy later on down the line. And then for these ascending cholangitis patients, all of these patients will be admitted as well. They're going to get a consult to GI for maybe an ERCP or ACS for a cholecystectomy. A lot of times they may even have to put like what they call like a chole tube and allow for like drainage of the gallbladder. Really, it's case by case basis, and it's depending kind of like on how sick these patients are. But almost all of these patients will be admitted, and we'll have some sort of intervention like fairly soon. Any questions on that at all? Cool. And then again, just some other differences for right upper quadrant pain. Any sort of gallbladder disease, obviously hepatitis can present as like acute onset abdominal pain, right upper quadrant pain, with like jaundice, and there's Hep A, Hep B, Hep C. Hep A is like normally like your more acute ones. A liver abscess, especially in like your immunocompromised patients. I've seen a couple of those. Bowel obstruction can present this way. Appendicitis is not always in your right lower quadrant, unfortunately. Everyone's anatomy is a little bit different. Classically, it's there, but especially in like your pregnant patients, that uterus will displace your appendicitis or your appendix, and you can actually have right upper quadrant pain, and it's actually appendicitis. Pyelonephritis, any sort of like GU infection or like kidney stones, anything like that can obviously present this way, and then ACS as well. So really anything, and especially like in your like epigastric region, right upper quadrant region, left upper quadrant, anything like that, especially in like your older patients or patients with a lot of comorbidities, always just have ACS in the back of your mind. It can be really sneaky, unfortunately. All right, left upper quadrant pain. We'll try to motor through these just a little bit faster. So 75-year-old male called out for left upper quadrant pain. Began acutely 45 minutes ago. It's been persistent and worsening. It's non-radiating. He has hypertension, diabetes, GERD, osteoarthritis, and coronary artery disease. Vitals are fairly stable other than tachycardia. He's borderline temp, and then he's uncomfortable. He has severe tenderness to his left upper quadrant, and he's got some mild abdominal distension along with it. What do y'all think? Good thought. Anything else? Could be gastritis, could be gastroenteritis. He's a little bit more sick than that, but obviously could be something like that. But this guy actually is perforated ulcer. Nice. So this is peptic ulcer disease of the bowel perforation. So the big things that are pointing you towards that, especially in his history, is, osteoarthritis. You imagine he's got frequent NSAID use, and it's like acute pain with some abdominal distension is pretty classic for that, right? So this is actually like a EGD of like a ulcerated mucosa of like some gastric mucosa. So they can have recurrent ulcerations. Majority, it's actually related to H. pylori, which is a gram-negative bacteria that's kind of pervasive around the world. And then obviously in the United States, NSAID use is also pretty common. They can have this burning epigastric pain, typical with eating. And if perforation does occur, they'll have like acute onset of like severe pain. And then if it's significant, they can actually erode into surrounding gastric vessels, and they can have some pretty significant GI bleeding with this as well. So they can present with like hematemesis and all sorts of other stuff. So obviously interventions. For their hemodynamic instability, fluids have felt appropriate, but limit large fluid resuscitation to avoid like dilution and anemia, especially in the setting of like possible GI bleed. And if they are bleeding, and if you've got the time, any sort of blood product you can give these patients will help them if they are like having like perforation with bleeding. And then if they're bleeding, they're having massive hemoptysis, always any airway protection you can do, whether it's suction, oxygen, proper patient positioning, and even intubating if need be. And then again, analgesia and rapid transport. And so this is actually an X-ray that you might see with some of the bowel perforation. And what you're seeing there with the arrows, that's actually elevation of the diaphragm and air under their diaphragm. And there should never be air under your diaphragm unless you've had like a recent surgery or something like that. And so that's bad. If you see that, that's bad. You're calling your surgeon regardless of if you got labs or anything or not. That's bad. And again, we're going to assess for hemodynamic instability again. Get all the labs you see there, especially like a CBC and LFTs, ECG troponin. And if they're stable, we'll get a CT scan. But if they're not, if they're unstable and we're concerned for this, it might be a reason why we might get like an X-ray or acute abdominal series just to see what's going on. So for these patients, if they're not perforated and they overall are stable and their vital signs look good, once they've gotten some pain control and their electrolytes look okay, they can typically go home and essentially we'll stop their NSAIDs and tell them to like stop any sort of like alcohol use, and then we'll either start like a PPR and H2 blocker, and then You can't really evaluate for H. pylori in the emergency department. There's a bunch of tests that go into that, but it's something they'll have done outpatient. And if they do have it, then there's several different medication regimens they can go on. And then obviously if it's perforated, they're going to be admitted. They're typically going to get like an emergent surgery consult, broad spectrum antibiotics, and the full bit, and they will most likely go to the OR. And then just a couple other differentials just to look at, other than peptic diseases, can always just be GERD as well. Splenic infarct, your spleen is in your left upper quadrant, so especially in like your patients with like AFib or patients especially with like sickle cell disease, splenic infarct is something you always need to be thinking about. Bowel obstruction, pyelo, herpes. Always try to undress your patient if you can, or at least take a look at where they're complaining of pain at. I've had that happen a couple of times where they came in and they've just got like this raging rash in like the dermatomal distribution, and it's like a herpes zoster. Pneumonia, MI. There's all sorts of things again that can present this way. All right, right lower quadrant. 17-year-old female, right lower quadrant pain, began a day ago, has been worsening since that time. It started around her umbilicus and has since moved towards her right lower quadrant with some associated nausea and vomiting. Vitals are stable, and then she's like mildly tachycardic, she's mildly febrile, and then she's in mild distress with some right lower quadrant tenderness on palpation with no rebound or guarding, or with mild guarding but no rebound, and then no obvious masses or hernias. So what do we think this is? Great question. You can say like last month. But great question. Any female childbearing age, you always want to ask that. Could be. Mm-hmm. Mm-hmm. Well, what's the one other thing we always think about? Appendicitis. This one is actually appendicitis. It's not any like sort of weird ones. So again, it's just acute inflammation of your appendix. So it's most commonly caused by like there's some sort of luminal obstruction of your appendix. Typically it's like a fecalith. Or a lot of times with kids, it can be like after like a viral infection or something like that, they can have like inflammation, or they can have like that can cause this obstruction. It's the most common non-obstetric surgical emergency in pregnancy, and it's typically the most common surgical emergency overall, especially in patients younger than 50. So again, patients that are pregnant can have other things going on. So if they're complaining of abdominal pain, just make sure we're thinking about other stuff other than just something might like related to their pregnancy. And again, so they'll have some malaise, some anorexia. They won't want to eat, nausea, abdominal pain. Typically, it will be very vague pain initially while this inflammation is happening, and then slowly but surely it'll kind of migrate more towards their right lower quadrant, and there'll be more focal pain. And then any sudden improvement of their pain can also suggest that they've had like a perforation of their appendix. And then that McBurney's point, kind of what you were talking about earlier, that's right where that number 1 is, right? So it's kind of like about a third of the way from your right lower quadrant and your umbilicus, and that's pretty classic for appendicitis if they've got tenderness there on palpation. And then Rosving sign, so that's actually if you press on someone's left lower quadrant and it hurts in their right lower quadrant, that's like another sign that they used to use a lot as far as appendicitis goes. Then psoas sign, so that's like you can like move a patient's leg, and I'm not going to demonstrate for you right now, but and if it can, the appendix can actually rub against your psoas muscle, and that can cause some pain as well. So that's another sign you can use for appendicitis. So again, like all the other patients that we had, it's just ABCs initially, right? So if they're unstable, obviously aggressive fluid resuscitation, proper analgesia, and then also keep these patients NPO, and then try if you can to transport them to a hospital with surgical capabilities. So if it's a child, especially taking them to somewhere like Children's or something like that, if this is something you suspect, is always helpful. So in the emergency department, depends on where you are, right? So obviously we're going to do like our ABCs and pain management and everything like that. And then the labs are normally like fairly similar as far as adults versus kids. We're going to get like a CBC and a CMP and LFTs and a lipase and a urine pregnancy test, lactic if they're sick. And then in pediatrics, they'll also normally add a CRP and an ESR. We don't really use that in the adult space very much, but they use that a lot in kids to kind of diagnose or try to risk stratify these kids. And then in pediatrics, if they can, ultrasound is the standard of care. They're very good at ultrasounding for appendixes in pediatric patients and being able to look at their appendix that way. But for adults, it's obviously a CT scan is what we're going to do. And the disposition, they're always going to have a surgical consultation and admission for surgery versus antibiotics. Some of these folks, if they look really, really stable, and their CT scan is not incredibly impressive, they actually might try IV antibiotics first, and then some of them, especially if they're pretty sick, they'll try it and do surgery first. And most of the time when kids, they'll just go ahead and take it out. A lot of times, if a kid comes in for appendicitis and it's early enough in the day, they may even leave the hospital that day, later in the day, depending on how fast they can get in surgery. That's happened a couple of times while I've been over at Children's. And then just looking at the CT scan, the arrow is just showing inflammation around the appendix. The appendix is, at least for me, I don't know about y'all, one of the hardest things to find on a CT scan. Sometimes I feel like I can see it, sometimes I feel like I can't. It's super hard to find. A lot of radiologists have tricks for it, but I have a really hard time finding the appendix unless it's really inflamed. And then that black area you see, that's actually a big, like a fecalith that's obstructing their appendix, and their appendix is pretty distended there. So, any questions about appendicitis or anything like that? And in kids too, I know pain medication, pain control is really difficult in kids, and I don't know exactly what y'all's protocols are for peds, but even at the Children's Hospital, a lot of times they're going to give these kids Toradol, and then, if that doesn't work, they're going to give these kids morphine and stuff like that to make sure their pain's under control. And then, as far as your other quadrant, you can also have like Crohn's disease flares, hernias, ischemic colitis, any sort of GU pathology, kind of like we touched on, like I think, we said ectopic and everything like that. So again, a lot of things can masquerade as this. So we got a couple more. We're going to try to motor through. So left lower quadrant pain. 24-year-old G1P1 female called out for left lower quadrant pain. Began earlier this morning. Has been constant. Has some nausea and vaginal bleeding. She's using a pad every hour for the last 6 hours. No discharge. She has one previous pregnancy. She's history of hypertension. She is sexually active and has not used contraception. She is hypotensive at 90/60. She's tachycardic. Otherwise, she's pale, diaphoretic. She's responsive but uncomfortable, and she has some left lower quadrant palpation, active vaginal bleeding. This is actually essentially the exact case of a girl that I saw a couple months ago. So what do we think? Yeah, I'd say that's definitely top urinary differential. And just for time's sake, it is ectopic pregnancy. Nice. And this one was supposed to be, fairly obvious. So ectopic pregnancy, these patients can be very, very, very sick. It's the leading cause of death in the first trimester, and the third leading cause of death, maternal death overall in the country. It occurs in approximately 2% of all pregnancies. And then there are several risk factors, but if they've had a previous what they call tubal pregnancy or ectopic pregnancy, and then previous pelvic inflammatory disease, if they have an IUD, there's all sorts of things that can be high risk for ectopic pregnancy. And then clinical features, if it's non-ruptured, which is early, they'll have some abdominal pain and some vaginal bleeding. But if it's ruptured, they'll have they could be in hemorrhagic shock. They'll have like a peritonitic abdomen. They can be fairly, very sick. And the girl that I saw, kind of what I based this case off of, she came in, she was speaking to us, but was obviously like very, she was very drowsy. She was very, very pale. I think when they took her up to the OR, she had like 2 or 3 liters of blood in her belly. I mean, she was really, really sick. I think she got 2 or 3 units with us before she went upstairs. And I mean, she was only in the department for 30 minutes total or something like that. She got upstairs really quickly, but they can be very sick very fast. And this is just a brief overview of, just the anatomy, like pelvic anatomy. And again, a lot of times these ectopic pregnancies, they're going to implant somewhere here along this track here. Like here's their ovary, and then here is their like oviduct. And there's our ovarian ligament. And so a lot of times anywhere in this anatomy right here is where this is going to implant. And they can, as the fetus grows, any rupture there can cause a lot of bleeding. So obviously, like we've been talking about, just stabilize these patients as best you can, especially if you're concerned for hemorrhagic shock. Blood is going to be the biggest thing with these patients before they get to the hospital. To just kind of keep them stable, and then just rapid transport. And then if they are stable, just any sort of analgesia and nausea control you can do on the way is helpful. And so for these patients, it's going to be a really rapid assessment, especially if they're bleeding, profusely and they're fairly sick. Obviously, we're just going to go ahead and call OB down. We're not going to wait for labs or anything like that, but we're going to get at least a CBC to check their hemoglobin, a beta HCG, and a type-in screen. And that's for any patient, whether they're stable or unstable. And then if they're unstable, we're just going to do a fast and look and see if they've got any fluid in their belly. And that girl that I told you about, she had a lot. It was very obvious. And then if they're stable, we'll do like a pelvic ultrasound and assess for an IUP, which is an intrauterine pregnancy, and if they have any free fluid. And then regardless, we're going to consult OBGYN. And so for these patients, If it's a small ectopic pregnancy and it's like minimally symptomatic and there's no hemodynamic instability and there's no evidence of rupture, they actually may be able to be discharged home with a very, very, very close follow-up with OBGYN. And essentially what they'll do is they'll kind of measure serial beta HCGs to make sure it's trending downward appropriately, and they'll start them on methotrexate. And there'll be like very, very close follow-up with very strict return precautions, essentially that like, if you start to have any worse vaginal bleeding, any worsening pain, anything like that, come right back. Because this, even with the methotrexate, they can still have like ruptured ectopic pregnancies. And obviously, if it's ruptured or there's any hemodynamic instability, they're going straight up to the OR level 1 to get this taken care of. And then they can, you can also have diverticulitis, inflammatory bowel disease, hernias, infectious colitis, mesenteric ischemia, any sort of GU pathology, whether it's ovarian or testicular torsion, which I think we mentioned for the right lower quadrant case, UTI, anything like that. And so real quick, and I've mentioned it a couple times, I just wanted to go over 2 pathologies real quick that can essentially kind of present as almost anything. The first one being AAA. So obviously the aorta is a massive vessel. It runs all the way from your thorax all the way down through your abdomen. AAAs are fairly common. 85% of them are below the kidneys or infrarenal, but they can essentially be anywhere. And their median growth rate's about 0.2 to 0.3 centimeters a year, but as they grow, the chance of them rupturing increases. And so we have pretty good data that shows anything below 4 centimeters is fairly low risk, but once you get to like 4 to 5, the 5-year risk is about 3 to 12%. If anything over 5, your risk skyrockets as far as your chance of rupture. And if these things do rupture, they have a very, very high mortality, regardless if they get intervention or not, just because they can bleed out very, very quickly. So even with open aortic or endovascular repair, these patients still do fairly poorly. And then risk factors, the male to female ratio is 4 to 1. Smoking is the most direct relationship. Something about the inflammation from smoking kind of breaks down the intima of your vessels and can cause this aneurysm, and then can also make it more apt to rupture as well. But then they can also have family history, hypertension, hyperlipidemia. And so again, just looking at the anatomy, you can have thoracic aortic aneurysms, abdominal aortic aneurysms, but a lot of times they're infrarenal, so they're below the kidneys. And this is just an ultrasound showing like an actual aortic aneurysm, and so a lot of times they'll be asymptomatic if they're unruptured, and so you may just have like a pulsatile mass, but they're asymptomatic. But once they do rupture, they'll have abdominal pain, hypotension, and their pain can essentially present anywhere in the abdomen or chest, depending on where the actual aneurysm is at. And a lot of times it's described as like a ripping, like sudden pain. And typically these patients, will be very, very sick very quickly. And they can have like retroperitoneal hematomas. They can even have what's called an aortoenteric fistula, which is essentially just your aorta, the aneurysm will erode into like your bowel, and then you can have just massive GI bleeding. And these patients will get like coags and everything, but imaging is the main thing that we need for them. So normally we'll get an ultrasound, is actually very, very accurate in like assessing for any sort of AAA, and then we might get a CT as well. So that top one is just an ultrasound. So if you see like the more dark part in the middle, that's kind of like the actual lumen, and then the lighter part around it where the arrows go to, that's the actual aneurysm itself, and it's got like a big thrombus in it. And then the CT scan shows like the really dark part, and then the actual white part where there's still like blood flow. That's where like the contrast is going. That's like a fairly large aneurysm right there. And again, so dispositions for these patients, if they're asymptomatic, they just have very, very prompt follow-up with vascular surgery, and it kind of also depends on their comorbidities, whether they may stay in the hospital or not. And then if it's ruptured, obviously, then they're immediately going with vascular surgery or to the OR, and they're going to get either some sort of like endovascular repair or like even maybe open repair if it's bad enough. And for these patients, and it's somewhat similar to the thing we're going to talk about next, is impulse control is really important. And so you're trying to keep their blood pressure fairly low, and you can even allow for permissive hypotension in these conscious patients. So as long as they're conscious and talking to you somewhat, that's okay, because we're trying to kind of keep their blood pressure a little bit low to decrease like the shear forces on that ruptured aneurysm. And secondly, aortic dissection, a somewhat similar pathology. Nice. Bye, guys. Sorry. Aortic dissection, just briefly, it's just a tear in the intima of your aorta. Most commonly seen in 60 to 80-year-old males, but can be seen in almost anyone. I've seen someone as young as I think like 40 that had an aortic dissection. Also, again, very, very high mortality, especially in the setting of like delayed diagnosis. See you guys. And risk factors are hypertension, tobacco abuse, hyperlipidemia, diabetes, any sort of connective tissue disorder, anything like that. Again, it'll be like a tearing, ripping pain to their back and their chest. They will have neurologic deficits a lot of the time, so they may have like numbness or like tingling down one of their extremities. They could have pulse deficits, and so that's something that we a lot of times, especially if they're describing pain like an aortic dissection, a lot of times you're doing like a full neuro exam, a full vascular exam, making sure they've got good pulses and like good neurologic status. And then, if it's in the ascending aorta, they can have tamponade from this, hemothorax, all sorts of stuff. And if it's this descending aorta, they can have like hemiplegia, neuropathy, renal failure, mesenteric ischemia. It can present in a multitude of ways. And so essentially gold standard is a CT angiogram. That's what you're seeing here. And so like the big circle overall is the aorta, and then you'll see that little flap, and then right and like where the black arrow is, that's like the lumen of the aortic dissection itself. And there's two classifications. There's whether it involves your ascending aorta or if it doesn't. If it involves your ascending aorta, it's a type A, and if it doesn't, it's a type B. And type A's are almost always surgical, whereas type B's, they can actually typically be managed medically and observed. And so the big thing for these people is pain control, and normally they'll get an ART line for blood pressure monitoring. And kind of like I was talking about with AAA, they can have what's called impulse control is what we do. So we're trying to target a low heart rate and a low blood pressure to reduce like the shear forces on that aorta and that dissection to kind of keep it from growing. And so our heart rate goal is normally less than 60, and our blood pressure goal is about 100 to 120. That's where we get the ART line, so we can be as like sure as possible like what our blood pressure is. And so typically we'll do like a beta blocker, like an esmolol, along with like a calcium channel blocker, like a nicardipine or clobetapine, to try to control their blood pressure and their heart rate. And then again, type A, they're going for like emergent surgery. And then a type B, they may need surgery, but a lot of times they can be medically managed with heart rate. And then just a couple other atypical etiologies real quick. And I've kind of touched on it before, ACS. So they can present with, any sort of epigastric or upper abdominal pain. Pretty common in like elderly diabetics and women for it to present this way, like sort of atypically. So just remember, in a lot of your abdominal pain patients, always think about getting like a 12-lead EKG en route. Pericarditis, again, it's inflammation around the pericardium of the heart, can also mimic epigastric pain. Normally it's like follows like a viral prodrome, so it's something to kind of keep in the back of your mind. And then heart failure, hepatic congestion can also present with like right upper quadrant pain and like fullness. And a lot of times these patients will look volume up, and they'll have like distended abdomen and all that sort of stuff as well. And then special populations, real quick. Pediatrics, they can have special stuff in their belly. Adults can get intussusception too, but it's far more common in pediatrics. They can have pyloric stenosis. They can have non-specific viral abdominal pain. And the big thing for kids is just making sure their fluid status is appropriate. Oh, we got another one? Oh, we're good. Okay, cool. And then pregnancy. Just any woman of childbearing age, consider an ectopic pregnancy until proven otherwise. And then appendicitis can shift. A lot of their bowel can shift with their uterus, and so they may present atypically even with like kind of normal abdominal complaints. And then elderly, kind of what we talked about before, they can have very atypical presentations. They're more likely to have like ischemia or like a AAA just based on their age. And almost all of our attendings, again, they'll tell you that elderly bellies will lie to you. So just be kind of aware, or just have a little bit higher index of suspicion with your elderly patients. And so again, just some take-home points. And it's the same for us in the department, follow your ABCs. The differential for abdominal pain is broad. Just try to use it was like a focused physical exam and their history to try to help narrow down your differential and kind of like what you might do next. The quicker we can identify signs of septic shock, GI bleeding or hemorrhage, or like peritonitis, and initiate rapid transport, the better off these patients will be. Proper resuscitation will save lives, so don't be afraid to give fluids or blood, especially if you believe it's clinically indicated. We trust y'all. We know that you're well trained, so just trust the training you've gotten. And I'm never going to fault anybody for like giving blood or giving fluids if you thought it was appropriate. And then just remember your special population, especially your elderly and your immunocompromised. They can harbor pretty serious pathology without an impressive exam. And then again, females of childbearing age with pelvic pain, they're ectopic pregnancies until proven otherwise. So just try to always have that in the back of your mind. Any questions? I know there's a lot. It's a lot in the belly, but.
Go back to the case you had with the top.
Sure.
So
Mhm.
how suspicious it is.
Yeah.
That's all we got.
Sure. So the question was, in a patient with ectopic pregnancy, like when is TXA contraindicated? To be honest with you, I've never really given TXA in an ectopic pregnancy. I don't really know exactly what the OB literature says about giving TXA in ectopic pregnancy. In trauma, we give it, within 3 hours of a traumatic injury. But
Just looking for
Yeah, she's hypotensive, you know. I mean, the main thing that she needs is blood, obviously, or fluids if that's all you got, something at least to kind of support her blood pressure. But as far as TXA itself, I'm not exactly sure. Ferg, what do you think?
Yeah, I would say that if you think they're in hemorrhagic shock, the risk of TXA is not much. So risk to benefit, they will get TXA. Okay. So if you got a person, a female of childbearing age, even if that period was 2 weeks ago, it's not that we don't trust people, but we take the risk to benefit, right? And she is hypotensive, pale, tachycardic, unresponsive to a fluid bolus, and her belly is tender. In my mind, that's an ectopic pregnancy until proven otherwise.
Mm-hmm.
And that's hemorrhagic shock. So yes, 2 grams TXA.
Yep.
So the question was, do we use that for a GI bleed? This is where docs argue over this one.
Yeah.
So you got a couple schools of thought. There was a study several years ago that talked about the mortality for GI bleeds increased with TXA use. But if you dig into that research, they were doing 1 gram. They were giving an 8-gram infusion. They were starting this 12 hours into the game. My thoughts, the way I practice, if I have someone that's having an acute GI bleed, they're throwing up bright red blood, they're pooping bright red blood, and they're hemodynamically unstable, and this bright red blood started within 3 hours, they get TXA. Okay. So if you got the little old lady that's got a slow GI bleed, she goes to the hospital every 3 months to get blood products for her slow GI bleed, she does not need TXA. But if they're crapping bright red blood and unstable, heck to the yeah.
Very good. Thanks, Doc. We appreciate the lecture.
Of course.
Everybody online, please remember to fill out an attendance form. The link is in the Q&A. We're going to take just a couple of minutes break to let everybody stretch a little bit, and then we're going to come back with Dr. Sullivan, so don't go anywhere. Hey, everybody. Welcome back. We got Dr. Sullivan is going to talk to us about some extremity trauma. Is that right, Doc?
Yeah, pelvis and extremities. So the pelvis, yes. Looks like we got a few more trickling in, so we'll get started in just a second. All right, you all ready? Let's do it. I am Tyler Sullivan. I am one of the EMS fellows with UAB and Birmingham Fire. I came from the distant land of Mississippi, came over to civilization in Alabama for my residency, and subsequently stayed on for fellowship. Got a wife and 2 kids and a golden retriever. I tried to upload some pictures to the slides of my kids. They have fireman uniforms. I talked to my son about like what I do. So when I go and ride with EMS, I'll talk to him and he's like, "Daddy, did you go to the fire station?" I'm like, "Yeah." And he's like, "Did you see a fire truck?" And I'm like, "Yeah." And he's like, "Are you a fireman?" And I'm like, "Nah, buddy." And he's like, "Well, what are you?" And I'm like, "A doctor." And he's like, "Oh." So my son appropriately thinks you guys are the heroes. So he knows the truth, and he's fired up about it every time I get to tell him about it. So a lot of people are looking up to y'all, as you already know. So today we're going to talk about the pelvis a little bit. We're going to talk about extremities. We're going to talk about traumatic injuries. This talk is not going to reinvent the wheel. I'm not about to present you with groundbreaking information, but hopefully this is going to be high yield review or solidification of your foundations in going out and taking care of injuries to the pelvis, injuries to the arms or legs. So big picture here, there can be some serious life threats and isolated injuries, particularly in the pelvis, which we'll cover first. We'll talk about blunt and penetrating mechanisms, differentiating between the two, other than the obvious visual stuff. We'll talk about pre-hospital management, what you guys can do early that can give us demonstrable results and really improve patient outcomes. We'll talk about triage and transport considerations, pelvic binders, tourniquets, TXA, open versus closed fractures, and the complications of all of those things. So we'll jump into it. So pelvic trauma, why this matters. Major cause of pre-hospital death and blunt trauma. You guys are the first line of intervention. You guys are the first ones on the scene. You guys need to be able to identify when someone has a bad pelvic injury, so you can slap a binder on there, resuscitate appropriately with fluids or blood, whatever you have available, give TXA, and get them to the hospital. Time is blood, like time is brain, time is all this stuff. We need you. So only you can prevent severe hemorrhagic shock in the pre-hospital setting. So let's talk about it. So pelvic trauma, we have blunt. Most commonly, this is going to be an MVC. That's where 90% of these are going to come from, particularly side impact MVCs. We'll talk about various mechanisms of pelvic fractures, but side mechanisms are a major cause. Crush injuries, getting run over by stuff, and then falling off of things, ladders, roofs, trees, etc. All the things that people like to get up on top of. And sometimes it's just an old person who fell down. Doesn't take much sometimes. Penetrating, gunshot wounds, impalements, interestingly, blast fragments from explosions, whether that's military, law enforcement, or if that's someone working industrial. The big takeaway from this is going to be anything that you're suspicious for pelvic trauma, particularly in a blunt mechanism, do the pelvic thing, suspect a bad pelvic injury. You'd rather miss in the affirmative than miss in the negative. So the pathophys of this, why pelvic trauma is important and dangerous, specifically important to recognize. There's a lot of space down there. There's also a lot of stuff going on. If you've ever looked at like a high quality like gross anatomy picture of a pelvis, it looks like a bowl with a bunch of big and little noodles in it that are full of blood. The pelvis, when it breaks, is very jagged and very nasty, and it does not take much for it to bump into those vessels, open them up, and then there's no way to compress that. There's only surgical or like IR intervention for those things. And surgery for those things is not easy either. So your early recognition of this is of utmost importance. They call it like hidden bleeding. There's not a whole lot of physical exam findings that you're going to see when you roll up on a patient. There's not going to be like a particular clinical sign, like a battle sign or whatever for head trauma. You're not going to see this thing that says like, oh, there it is, pelvic hemorrhage. Here we go. Open book fractures are going to be your more obvious things. These are associated with very high mortality. So all this just to reinforce the importance of recognizing this and suspecting it early. That is a kind of reconstruction of what the bowl of noodles looks like. Not that it makes a huge difference, but red is representing arteries, blue representing veins. Most commonly, the bad bleeders are going to be venous bleeders. They're not as fast, but they ooze. They don't vasospasm like an artery does. They're not surrounded by a little layer of muscle as much as an artery is. So they'll just sit there and bleed. So what to do? Here are the types of fractures. Like we talked about, most commonly we see a lot of lateral compression if you get a bad pelvis. We'll talk about the specifics of that. Then you have vertical shear, the windswept pelvis, and then you have AP compression. So you can kind of make sense of those things when you think about their fracture patterns with what type of vector of force went into that pelvis. So like lateral compression, side impact, AP compression, you think about a pelvis like kind of the wings coming out towards you, just think about taking a hold of those and pushing them back. So a real bad like anterior to posterior force. Vertical shear coming up from below, so think someone with like that fell from a height, landed on like a kind of a straight leg and forced that straight up into the pelvis. And windswept comes from, I guess, a variety of mechanisms. Vertical shear, high mortality rate, real bad about that pubic ramus and those little shards down that you see at the bottom kind of going up into the pelvis, where there are a lot of major vessels that course through. Your iliacs that turn into your femorals are going through right there. Also, your sciatic nerve is very close. So bad news in a vertical shear. Hypovolemic shock in upwards of 63% of these patients, and as stated, high mortality rate. In a lateral compression, you have a couple of different variations of that. Not super important for you guys, but there for you. Basically, it's 1, 2, and 3 just shows like various extensive fractures, various degrees of separation, and how far and how extensively these are damaged. And as you can see with the demonstrated by the little red arrows up in the top right, that's kind of where your vector of force is coming from. In the AP, as we talked about, this is more of like the anterior posterior force, as explained, kind of breaks off at kind of the SI joints there. They also have grades, kind of type 1, 2, and 3, depending on the severity and how much disruption of like the SI ligaments or the sacrospinous and sacrotuberous ligaments there is. Obviously, the higher the degree, the worse. More vascular and neurological injuries associated, the higher degree you make, which doesn't take a rocket scientist to kind of guess that. The worse the fracture, the more likely there's going to be bad complications. So what do you do when you roll up on a patient and you suspect that there could be pelvic trauma? It doesn't take a whole lot. There's not a whole lot of cool physical exam things to do. Really, I think all we need to do here is place your hands kind of on the greater trochanters or up on kind of the wings here, kind of right where your like hip bone sits, and just give it a gentle push. If it's really bad, you might feel some instability. I personally have pushed on a lot of pelvises that have been broken in many different ways, and not a lot of times have I ever rocked this pelvis in a way that I was like, oh gosh, this is like unstable. Frankly, like a lot of them are still feel pretty stable. But what did happen was that patient screamed at me or cursed at me or tried to hit me because it hurt very, very bad. So if you go and check out a patient that's been in a high mechanism, MVC or something like that, and you give that a little push and they shout at you, you need to suspect pelvic injury. So pre-hospital management of these, once you've identified that I suspect a bad pelvic injury, you're still doing your ABCs. You're still sticking to the trauma algorithm. You're making sure that their airway is patent, that they're breathing, and they have bilateral breath sounds, and that they have good pulses elsewhere. Next up, you want to get these guys in supine positioning. You don't want them to move a whole lot, and we'll get to why. Pelvic binder. This is probably your highest yield thing that you can do aside from giving a patient blood that's in a hemorrhagic shock. And we'll talk also why. Then alerting this patient because mechanism of injury, suspected pelvic injury, and then establishing your IV access, thinking about TXA, and thinking about giving blood or fluids, whatever is indicated in your protocols and whatever you have available. So the binders. Most importantly, in placement of a binder, once you've recognized the pelvic injury, once you've recognized the need for a binder, is the placement. There are various different kinds of binders, different departments carry different kinds, so we're not going to go into like all the different kinds that you have. Most importantly, in regards to the kind that you have, just be familiar with the one that you use. Get it out, mess with it, figure out how to get it tight and cinched down. Make sure you know how to operate it before you have to go and slap it on somebody. If you don't have access to that, a sheet is fine. And I have a graphic coming up that we'll talk about. But placement. Once you know how to operate it, know how to get it cinched down, placement. It's not up here on the iliac wings. It's not down on the femurs. It's the trochanter. You want to feel the bony aspect of like the lateral part of their hip, kind of midway along the glute. That's where you want it cinched down. Up here, you might not get as much compression because where the blood is pooling is typically down in the bottom of the pelvis. Up here, you're not really compressing a whole lot, and you're still leaving the bottom of the pelvis kind of wide. Too low, you're just squeezing your legs together. But across the trochanters, you're really getting down into the actual body of the pelvis, and you want that cinched down as tight as you can get it. You want to leave that in place. Once you've made the decision to do it, don't move it. Cinch them down, leave it alone. They may complain. They may say it hurts real bad. Don't move it. Don't want to move these patients around either. So I know a lot of log rolling and things like that when you suspect back injuries, things like that. You don't want to move these guys if you suspect bad injury because that can move those kind of sharp shards around in that basket of noodles and potentially risk making the injury worse. So You want to get this on quick. Once you suspect it, get it on there as fast as you can, but don't let it delay anything. These patients are typically have some kind of vascular injury. They're typically bordering on unstable or headed that direction. So you don't want to have to sit there and muck around with the pelvic binder. You want to get them and move. But once you recognize it, you want that thing on them quick. There is evidence that getting a pelvic binder on in the pre-hospital setting does decrease the need for transfusion in the hospital, and also shows some evidence that it decreases their length of stay. So you're having downstream effects. You're not just having good effect for you while you're taking care of the patient, but you're actually having demonstrable results that are later in their stay. The patients do better when you recognize this and get it on them. So what does it do? It cinches the whole pelvis down, which makes sense, right? It's a very difficult area to compress. You can't like take your hand and put manual pressure on it. You can't tourniquet the pelvis. So you do this to decrease the area of the pelvis, so where less blood can fill in, and you can hopefully tamponade that area, or at least make it harder to bleed. Most commonly, as I said, it's a venous bleed. A venous bleed is much lower in pressure than an arterial bleed. So it takes a little bit less pressure to stop that bleeding. So once you cinch them down and tamponade them down, if it's a big venous bleed, you can likely have some result just making it harder for that vein to pump out into the pelvis. So as I said, you get tamponade. And the reason we don't want to move those guys around is, as stated, a broken pelvis is likely shards, sharp edges, things like that. If you're moving the patient around, rolling them, putting any kind of like circumferential force on the pelvis, you're moving these pieces around in there with all those vessels exposed, and you can cause much worse vascular injury. Just to reiterate placement, that's kind of what we were going at earlier. You see too high on the left over the iliac wings, too low kind of down over the femurs, but just right there kind of over the trochanters, kind of right over the genital area, if that makes sense. So as we said, there's a bunch of different kinds. What's most important about the pelvic binders is that you're familiar with the one that you have, and that you know where to put it, and that you're getting it tight. So again, to reiterate the importance of stability, you want to try to disrupt or decrease your incidence of like hemostasis disruption. You don't want to bust clots loose. You don't want those sharp edges flying around. So a lot of words on that screen to say you don't want to move the pelvis. You don't want to risk worsen injury, and you don't want to make your patient more uncomfortable. It hurts when those things move around too. Now we got kind of some cool images, things that we see on initial trauma resuscitation. Typically they come in, we shoot a chest x-ray and we shoot a pelvis x-ray. On the left is a horrific example of an open book pelvis. That patient has multiple fractures, but the most obvious is that humongous space between the pubic rami and the pubic symphysis being that wide. The right is another pretty good example of multiple fractures, but again, an open book pelvis. This one's kind of cool. You can see this is some kind of 3D reconstitution. It's not particularly an angiogram, but you can see some of those major vessels that are floating around through there. And can y'all see my cursor? Doesn't appear so. Anyway, in the image to the right, there's a black arrow. If you look at it's approximately like 11 o'clock, you see this big vessel kind of coursing down the spine, and then it goes away and there's a bunch of just nastiness floating around in there. So that's an example of like a severed artery or vein there that's dumping blood into the pelvis. So anyway, blank screen for transition. Pelvic trauma. There's a lot of stuff going on, right? There's a lot of things that you could talk about. There's a lot of structures. But the main point of pelvic trauma is recognizing it, working your ABCs, sticking to your basic trauma algorithm, and making sure your airway, breathing, and circulation is intact. Recognizing the pelvic injury, putting a binder on, giving TXA as appropriate, giving blood as appropriate, pain control as appropriate, and getting to a hospital. Any questions on the pelvis? Cool. A lot of words to say a little, but it's extremely important what you guys do for folks with bad pelvic trauma. So to transition into extremity trauma, again, these can be isolated, and to the external eye, a lot of times on initial inspection or assessment of the patient, these can seem like somewhat minor injuries that can turn really bad and life-threatening pretty quickly. Granted, when you're assessing a limb and you see a Z-shaped arm from some horrible car accident, which I'm guilty of this too, being like, dang, look at that arm, like that's horrible. Don't let it distract you from the rest of your trauma algorithm. So just to throw that in there on the front end, I did this actually yesterday, had a great example of extremity trauma. I had this elderly female that fell from standing, and she horrifically broke her wrist. Her radius and ulna were both sticking out the bottom side of her wrist, and I could actually see her pulsating radial artery, which horrified me because I was like, I can see this lady's artery. She's going to bleed to death if I move her. But for a few minutes, I forgot. I was like, I got to work this lady up as a full-fledged trauma. I was distracted by this like crazy injury that I was looking at. So don't let the shock of seeing a horribly deformed limb throw you off of your normal trauma algorithm. The injuries are typically pretty straightforward. That's a line that I almost didn't put in there because I thought that was a little controversial, but typically it's going to be you recognize a bad fracture, you recognize a penetrating or a crush injury, and you can move forward with management. A lot of times these aren't necessarily life-threatening, but they can be. So don't let your guard down. Big bleeding risk, big permanent neurovascular damage, disability risk, and so important for you to get a good assessment on these and kind of recognize what you're dealing with. So the common types, bone fractures, joint dislocations, open or penetrating wounds, limb amputations, damage to nerves and blood vessels, sprains, strains, impalements, foreign bodies, compartment syndrome, bad complications, and crush injuries. We're going to skip through these pretty briefly, kind of a general overview of each, and then we'll hit the big algorithms at the end and nail some points home. So long bone fractures. These can be isolated. These can be part of a polytrauma. They can be open, which is a big risk of infection, disability, bleeding, all that kind of stuff. Rapid antibiotic administration is warranted if you're carrying Rocephin or Ancef. TXA, all of the things that you would typically think about in a hemorrhagic trauma, these folks are a little bit more at risk for. Versus a closed fracture brings a little bit different risk. This is not something like if there is major hemorrhage, it's going to be as obvious. If there's a femur fracture or a humerus fracture, those spaces can carry a lot of blood without you noticing it. You can carry upwards of like a liter in your thigh before it becomes super obvious that it's going on. So good compartment checks when you're dealing with a like old lady who falls and has a deformed hip. Getting a good assessment of her thigh every now and then, making sure it's not firm and tense. Very important to catch bleeding on the front end. As we talked about with fractures like heavy bleeding in the pelvis, same is true for those spaces like the humerus and the thigh. And big risk for compartment syndrome if that goes unrecognized. Dislocations. If there is no neurovascular damage, so you come up on somebody with a badly deformed wrist, which is exactly what I had yesterday. I'll use this example again. Her wrist was totally jacked up. I should have put the x-ray in here, and for some reason I did not take a photograph whenever I took it down and actually looked at the deformity. I think the shock value kept me from doing some of the more curious things that I would do. But you recognize this is a grossly deformed limb. You do your pulse motor sensory exam. If they have good capillary refill, have good distal pulses, have motor function, they can feel you touching, leave it alone. Put it in a firm splint, wrap it up, get to the trauma center, get to wherever you can get definitive management. If there is neurovascular compromise, if you have somebody with a purple hand that has no pulse, can't feel you touching, can't move their hand, this is a time where it may be indicated to give that thing kind of a gentle pull, or a subtle movement to try to get it back in decent alignment. But this is not something that you need to sit there and work on. This is not a multiple attempt thing. I think if you find someone who is clearly neurovascularly compromised, a little movement there to try to get it back in a proper alignment and see if you can get a better pulse back. I think that's a reasonable thing to do. But if that one kind of feint attempt does not do it, put them in a splint and get them to the hospital. Amputation. So you come up on a scene where there's a finger amputation, a hand amputation, something like that. Time is of the essence if there's going to be reimplantation. Typically very distal fingers, I haven't seen them put a whole lot of those back on, but if we're talking multiple fingers or some kind of big functional deficit, say you've got like a blue collar worker who lost his fingers at the sawmill or something like that, that's a person that they'll try to take care of and get reattached. You want to get them there within the first 6 hours. Obviously, this is, we're in the Birmingham area here, but I know there's probably some agencies listening in that are a little bit further and have a bit more prolonged transit time. So getting them to a center where there is appropriate care is important. Just as yesterday, I was at a hospital that did not have hand surgeons. We had a bad amputation. The hand surgeon was at the other hospital in town. And so making that decision could cut down, recognizing where the appropriate care is could be helpful. So knowing where your resources are. But what you want to do with the amputated digit, you want to wrap it in saline-soaked gauze. You want to shield it from direct ice contact. You don't want to cause like a freeze injury to the limb. You want it cold, but you don't want that limb, digit, whatever, directly on ice. So what I'd have you do is wrap that in saline-soaked gauze, put it in a plastic bag, and then put it on ice or put it in ice water. If rarely these things have significant bleeding. Typically, they are pretty easy to control. But if you're having issues, direct pressure at first, if you can't control it, a tourniquet may be indicated. But for the most part, these things don't bleed too badly, unless you're dealing with a major artery like at a wrist or something like that. But if we're talking fingers, hand, it's typically pretty hemodynamically stable. Neurovascular injuries. So the big risk of these is more along the lines of like dislocations of hip, shoulder, humerus, wrist, places that large vessels or large nerves kind of go through. This is where your motor and sensory exam is going to come into play. If you have a posterior hip dislocation, kind of bottom left picture there, you see the sciatic nerve courses very close to that. If you have a bad hip or something like that, there's pretty significant risk there of neurovascular injury with the neurovascular bundle that kind of floats right through there with the vein and artery as well. In shoulder dislocations, you have your axillary nerve that courses through there. So a lot of times you'll see kind of people with a decreased ability, decreased sensation to the kind of that proximal aspect of their shoulder, or inability to kind of abduct their shoulder. And then down through the humerus, you have your brachial plexus in the initial part. You have all of your brachial artery, brachial vein, all those that course through there. And then big nerve, we kind of remember with the humerus, we call it like the ARM acronym up the top. If you have a proximal humerus, it's like axillary nerve is at risk. At the mid shaft, more of a radial nerve. So you'll see kind of like your extensor compartment, and then down distally your median nerve, which can cause some big issues as well. So getting a good idea of pulse motor sensory again is helpful information for us at the hospital if you can identify that early. Crush injuries. These come from things getting run over. Big MVCs with high impact. Anything that causes prolonged pressure on limbs and specifically on muscle tissue. That lack of blood flow will convert that tissue into kind of an anaerobic metabolism, which is going to do a number of things. It's going to produce lactic. It's going to cause a lot of ischemia. a lot of damage to the individual cells itself. So when that pressure is released, you get them out from under a car, you get them unpinned, and blood tries to flow back in there. What happens is those dead or dying muscle cells will start to release their intracellular components. And the most important of those is going to be your myoglobin and potassium. Why is that important? So the myoglobin, a lot of times will come out faster than the kidney can process it. And what it can do is cause a lot of kidney damage, which adds into the next problem. You get a lot of potassium release. So once your potassium starts climbing from a crush injury, if you've got a ton of myoglobin, that's decreasing your kidney's ability to filter that kind of stuff out and regulate your electrolytes. You can start to see a rise in the potassium and risk of arrhythmia. I know a lot of you guys have probably seen or dealt with in the field folks with CKD or on dialysis that struggle with potassium or have coded in the field because of their potassium being 7, 8, 9, whatever. Kind of same issue. Young, healthy people with otherwise healthy kidneys after a crush injury are susceptible to hyperkalemia as well. And so you get all the kind of crush or compression syndrome, rhabdo, and associated electrolyte dysfunction, kidney dysfunction as a result of that. Impalements, obviously, bad deal. But how do you want to deal with it? Your gut intuition, the untrained person is like, well, I need to pull it out. A lot of times these impalements, if they do not damage major structures, major vessels, nerves, or major organs, people do pretty well. If they are so fortunate to have avoided a catastrophic injury initially from the impalement, they're probably going to do fine, unless whatever that object is gets jostled around or bumped around on something or moved around and then causes damage to the structure that it's near. So what I'd have you guys do with folks who suffer impalement injuries is secure it. If it's in an arm or if it's in a leg or if it's through somebody's thorax even, but they're seemingly stable or doing okay, lock the thing down, put some real bulky padding around it to where it's not going to move around as easy. You stabilize it at the place where it's entering the body, so it's not just like doing all this wiggle motion and bumping into all kinds of stuff inside the body. You want to cinch it down and just take them to the hospital in that way. Let the surgeons take care of that, but you just want to prevent further tissue damage with a mobile object. To cinch that thing down, tourniquets, all that kind of stuff is necessary if they're bleeding around it, but don't let it move. Don't try to pull it out. Compartment syndrome, as we talked about with broken femur, broken humerus, any type of crush injury, compartment syndrome is a serious risk. So what that is increased pressure inside of a compartment, whether that's due to blood, swelling, whatever, can be very bad, can cause permanent disability. See this every then in folks who have undergone orthopedic surgeries and go home and don't know exactly the things to watch for. They'll come back with a dead foot, dead leg, whatever, and lifelong disability. So the initial indicators, someone's going to have pain out of proportion. You're looking at a patient that doesn't necessarily have anything grossly wrong with them. They don't have any bones sticking out of their body. They don't look like they have a bad break, but they're having intense pain and they're having some numbness and tingling down through their leg or their arm. Compartment syndrome is something you need to think about. Start feeling their compartments and trying to recognize that something may be filling up and getting tight. So the later signs, once you start getting into full-fledged compartment syndrome, severe pain, we call it pain, pallor, pulselessness, paresthesia, paralysis, and those are the things you want to watch for. So if their foot down below their thigh is turning white, they don't have good pulses down in the foot anymore, they're writhing about in pain, can't feel anything down there and can't move anything, this is getting late in the game of compartment syndrome, so it's important to recognize that and get them to appropriate care. So back to mechanisms, blunt, penetrating, and the complications we've kind of talked through. Just recognize the appropriate algorithms to start following once you recognize what's going on, and early recognition of those, very important. So the initial assessment for these, once you start to recognize these things, stick to your algorithm, check pulses, check capillary control, sensation, movement, look for deformities, look for penetrating injuries, and control the bleeding. So hemorrhage control. Say you've got a penetrating gunshot or a stab wound, working through the first steps to the advanced ones. Direct pressure first, 2 hands if able. Don't release, just to check the wound. Don't look for a severity of injury. Just keep pressure there. Keep it for a fair amount of time, especially if you have a short transit time to the hospital. Just keep pressure. If that's not working, you can move to pressure dressing. Cinch that down with some like hemostatic gauze, an Israeli bandage, an ACE bandage, something like that. Get some good solid pressure on it, and monitor for bleeding through the bandaging. Some areas are not super amenable to direct pressure or to tourniquets or to things like that. This is like junctional penetrating trauma, like in the armpit, deep in the groin, base of neck, places that you can't get a hand into, places that you can't get a tourniquet around. This is when you want to start thinking about wound packing. So if you have somebody with like an impalement injury to the, into their hip or something like that, that's where you want to be putting either sterile gauze or TXA gauze if you have them. Pack it in there tight, and then try to apply some external pressure. Obviously, if this injury is out on an extremity and you've tried your other measures and you can't get control of hemorrhage, go ahead and place a tourniquet. So to talk a little more about specifics of wound packing, we've talked about or briefly mentioned kind of the places to go for it. Proximal limbs, neck, shoulders, hips, and groin. TXA gauze if you've got them. Sterile gauze will suffice if you don't. Pack the wound and then apply that pressure. Again, this is to kind of emphasize like junctional anatomy. There's not a whole lot of solid backstop on which to kind of apply that pressure. And there's a lot going on in these spaces. There's big vessels here because these are the proximal ones branching off of your aorta and subclavian and things. So very important to consider, especially in junctional trauma, getting the wound packing done early. So this is the kind of a detailed anatomy of the femoral kind of neurovascular bunch. At the top of the screen, you see the 3 big deals: the femoral artery, nerve, and vein. That's a place that you're also going to have a little bit of trouble up in the groin to compress. So consider that early. Importance of a tourniquet. Hemorrhage control, you got to weigh the risks versus the benefits. If you're close to the hospital, there's very little risk. You're not going to get significant tissue damage or necrosis from a 15-minute transport with a tourniquet. If for whatever reason you're going to be up to an hour, consider at some point in that hour taking it down to see if you've got hemorrhage control and then putting it back up if you need to. But under an hour, just leave it up. Record your times of when you've put it on. That's extremely helpful for our surgeons and trauma-based staff to know how long that tourniquet's been on, particularly if you're doing a transfer. Getting that information from the hospital that you're transferring from is extremely helpful. When in doubt, just put it high and tight. If it's down lower on the extremity, you can go more distal. So say you got a bad injury to like mid-calf or something like that you can't get control of. Yes, you can slide it up the thigh and put it on if you need to, if that's what you know and you're in a pinch and you're stressed. But you want to make sure that that you're doing this adequately, that you're not doing too much. You can go down more towards the injury. Just make sure you're about 5 centimeters proximal to that injury. And it is nice to have that as distal as possible with adequate hemorrhage control. And you can always put more than one. If you've got one on there, you can't quite get control, put another one on behind it. This is just kind of a cross section of a thigh. This is a good reason why you want a tight tourniquet. You can see how deep down and about the mid thigh all of those vessels are, and how difficult that would be to apply manual pressure to. and sometimes how deep that would be to try to get wound packing into. So that's why it's important to cinch those things down. So splinting, as we talked about, use your pulse motor sensory. If you've got a deformed wrist or something like that, check your pulse motor sensory, splint it up if you've got good cap refill, good sensation, and good motor. You'll want to recheck, which is kind of why I put this part in here. You'll want to recheck your pulse motor sensory after splinting periodically, every 5 to 10 minutes, just to make sure you haven't lost what you had. So if you had a pulse to begin with and you're 10 minutes down the road and you recheck and there's no capillary refill and their fingers are starting to turn purple and get cold, you might want to adjust your splint, adjust how tight you got your bandaging. Back to kind of hemorrhage, just to hit the high points. Pressure, compression bandaging, packing and tourniquets, considering TXA, pain control, and then fluids or blood as indicated by your availability and protocols. A few of just to run through a couple of the more common extremity traumas that you're going to run into. A humerus fracture here, you're going to see swelling, shortening of the upper arm, pain with shoulder, elbow movement. You might see some angulation, you might not. A lot of times these are badly deformed, but sometimes in little old ladies, they are not, when they just have like a little spiral non-displaced fracture. As we talked about, the ARM acronym, axillary up top, you've got your radial nerve kind of mid-shaft and then median down distal. What you want to do is either splint these, immobilize them, or put them in a sling, and check your radial pulses, neurovascular exam distally, kind of periodically. Shoulder dislocations, we see a lot of these. Anterior dislocations are by far the most common. Sometimes in like seizures, you see posterior because of the strength of your traps and things posteriorly, but for the most part, you're going to see anterior. You'll see a very prominent acromion. You'll see usually an obvious deformity to that shoulder unless there's a lot of swelling that makes it a little less obvious. But what you want to do for them is not try to reduce it in the field. I have certainly got a little zealous in the department and reduced these on my own and upset the orthopedics. Maybe because they thought they could do it better, maybe because it's a fun procedure. But resist the temptation and leave it alone. Put them in a slant, find the position that's most comfortable for them, whether that's down at their side or based on mechanism. If it's inferior, maybe above their head. Find the place that's most comfortable for them, treat their pain, and get them to the hospital. This is kind of a decent sketch of what you might see on a physical exam. You see how he's got his arm kind of held, abducted, kind of internally rotated, and you see the deformity up on his shoulder. All right, hip dislocations. Hip dislocation versus a femur fracture. A lot of times you will see in a dislocation an internally rotated and shortened leg. Why? Because typically these are posterior. You will see the ball of the femur actually get behind the pelvis, and so as such it kind of rotates it backwards, and so you get this internal rotation. But you'll see a short leg. There are complications to this. The sciatic nerve runs very close. A lot of times there's damage to that. You can get avascular necrosis of the femoral head, and a lot of times there's going to be an associated femoral fracture and acetab. What you want to do when you suspect a dislocation, stabilize the limb in kind of the position that you found it. Again, resist temptation. I've also reduced these prior to ortho consult, and they have been unhappy about that as well. So resist pulling on it, get them some pain control, monitor their pulse motor sensory, get them to the hospital. Tip fib fractures, see a lot of these. People step off a curb wrong, car wreck, whatever. You've got open fractures, obviously, versus closed fractures. As we talked about, the difference in open and closed kind of considerations for complication, whether that's infection, external hemorrhage control in an open fracture, or monitoring for a swelling compartment syndrome, or internal hemorrhage in a closed fracture. We've kind of talked about compartment syndrome and neurovascular injury extensively in this. We won't hit that anymore, but as far as you guys go, practical considerations are controlling bleeding, direct pressure, tourniquets if needed, cover the wound if it's open with moist kind of sterile gauze, and immobilize and monitor for any further neurovascular compromise. Femur fractures, another common one. Old lady fall down or a bad car wreck or anything in between. What you'll see here is typically an externally rotated, shortened hip. In this case, you do want to consider kind of pulling that leg into traction. Why that is? Mostly for pain control. So once there is a femur fracture, the most painful aspect of this is when all of the muscles around it are very irritated by these bone shards and start to cramp and cause them a lot of pain in that way. If you're not worried about a dislocation and you're fairly convinced this is a femur fracture and you're not worried about associated pelvic trauma, this is something that you may want to get into traction. One for kind of reduction of the fracture itself, but that's not the main point. Mostly this gives the patient some pain relief and makes your route a lot smoother to the hospital. So field notes for you guys. One, consider extensive bleeding into the thigh. Two, apply the traction sprint if you think this is an isolated mid-shaft fracture and you're not concerned about a pelvic fracture. IV fluids or blood for hypotension, TXA, all the hemorrhagic shock considerations. Pulse motor sensory and monitor for developing shock. All this a lot more concisely said than everything that I just gave you, but from our updated Alabama protocols for you guys as far as fractures and dislocations, which is mostly extremity. You want to get a good history, good physical exam. You want to make sure you're going to the right place, the appropriate level of care. Pulse motor sensory before splinting, after splinting, and then monitoring, therefore, to ensure that there is no developing neurovascular injury. Consider pelvic immobilization for pelvic fractures, pain protocol for treatment of pain, and then antibiotics if they're indicated and you have them available. And then lastly, massive hemorrhage, as we're talking about if these occur in pelvic trauma and extremity trauma. Tourniquets if indicated, and you can't control bleeding to the extremity traumas. Pelvic binders as indicated. Don't pack wounds in the chest or abdomen, pack wounds in the junction. Make sure you're doing those things appropriately. Fluid resuscitation, blood resuscitation, and TXA in the field. That was a lot. Anyway, that's all. Any questions?
Hey, Doc, we had one question online about pelvic binders. So any thoughts on pelvic binders for pelvic injuries or fractures that aren't open book? Any contraindications to using a pelvic binder?
I don't think so. And I would rather you miss in the direction of doing more than less. So especially in the situation of a significant mechanism trauma, even if there's no obvious open book or obvious instability, if you suspect it and you put them in a binder, no one's going to fault you for that. The trauma bay is always going to find something to criticize. So if you bring a patient that doesn't have a pelvis fracture in a binder, you'll probably hear about it. There'll probably be somebody chirp about it. But the fact of the matter is you took good care of the patient and you suspected that a pelvic injury and hemorrhage was possible and you intervened appropriately. So I would rather you miss in the direction of putting a binder on because there's almost no harm in it, than to be slow to the game on getting a binder on for like a subtle pelvic trauma.
Got it. So one thing I'd like for you to speak to, if you don't mind, having worked with EMS students for a number of years, there's almost consistently with every group a lot of confusion between crush injury and compartment syndrome. Mm-hmm. And a lot of people really get hung up on preventing acidosis and all that sort of thing that we see with crush injury type stuff that's extreme, that's the outlier, prolonged crush victims. and want to apply that to compartment syndrome. So could you kind of compare and contrast those two?
Yeah. So crush injury typically doesn't manifest unless you have prolonged interaction with the patient. So like, I'm trying to think of a situation in which you would have to worry more about this. Maybe a prolonged extrication that's like hours long or something along those lines. Do you need to start thinking about electrolyte abnormalities or things like that, or acidosis? When I think about compartment syndrome, one, it can be standalone, or two, it can be subsequent to a crush injury. Most commonly, I've seen compartment syndrome from snake bites, or not the most commonly, but more times than I've seen it from a crush injury, I've seen it from snake bites, and most commonly post-operative. So someone's had their ankle fixed, someone's had their femur fixed or something like that, and they get compartment syndrome.
So like hit by a pitch on the forearm can cause compartment syndrome.
Yeah.
At baseball. I've seen that a couple of times.
Yeah.
No
So
crush-
any
no
kind
crush
of
involved.
mechanism of trauma that may cause bleeding or swelling or edema in a compartment can cause it. And so yes, there are a lot of similarities in the two. In the fact that there's like muscle death, possible hyperkalemia, acidosis, rhabdo, all that kind of stuff. And crush injury can't cause compartment syndrome, but the two really are separate in that for compartment syndrome, the main concern is, yes, all those complications, but the treatment for that is going to be fasciotomy, opening it up and relieving the pressure, versus a crush injury is just going to happen because of the mechanism. So I guess what I'm trying to say is like, yes, they are related, but most likely they are going to present to you in different ways. And it's going to be obvious. They're going to be run over in the street over their legs and develop crush injury, compartment syndrome, versus you're going to pick it up. Somebody that says like, hey, I had surgery, yesterday, or I went to the ER, had a broken leg, got splinted and sent home with orthopedics follow-up in a couple of days. So they're going to present differently, but yes, there are some similar complications. They're similar, but different.
Yeah, one of the ways I think about it is that for crush is more a systemic response to what's going on, versus compartment is usually a limb or extremity isolated injury. Now it can get systemic at some point. And the way I would recommend, if you're thinking about crush injuries and you're thinking about, I'm giving my calcium and my bicarb, the way you're going to manage that is you're going to use your monitor. The redneck way to do it is you're looking at your cardiac monitor. If they're having a Y complex QRS, you're thinking they're now dehydrated and probably hyperkalemic. And at that point, you're going to start your aggressive therapy, fluid resuscitation, calcium, and bicarb for that guy. If their QRS complex is narrow, I would bet my $7 they probably are not hyperkalemic at that point. They could be going that direction. You still got to watch them. But that's my recommendation for when you think about pulling the trigger on giving your calcium and bicarb in a crush injury. So
That's good.
The pelvic binders, I agree. There's no risk to it, except you don't want to focus on pelvic binder on a polytrauma patient and leave the airway, the TXA, and the blood behind. If you have the resources to address the pelvic binder at the same time, yes, that is what you do. If you don't have the bandwidth, the resources to do that, then you do the things that you can do, which is things we know make a difference, which is securing the oxygenation, passive O2, airway management as need be, IV access for TXA, for blood products, which are a lot of places now, and hopefully coming to the region. So that's the only risk to that thing in reality.
That's a good point, because I think the pelvic binder can be very labor intensive for a crew on the scene.
Right. It can be, especially if you only pull it out every 3 years and it's dusty and yellow. So if you know how to put it on, you can put it on. More power to you. You laugh, but I'm being serious, and I'm right. So if you train with it, you know how to do it. Great. It's in your pathway. It's what you're doing. If it's something you got to figure out where it is, how to put it on, and you're delaying care, that's not appropriate. Okay.
Yeah, I hope I iterated that. Stick to your trauma algorithms
You did.
and let that be down there. Like you're saying, like know how to use the thing.
Yeah.
Don't delay transport.
Right.
For sure. Don't delay your management of how you would treat a trauma patient.
So one thing that always comes up anytime we talk about extremity injury at EMS Challenge is a femur fracture in the pre-hospital setting. So traditionally, we've used traction splints. I know in my career, I got to where I really didn't use them because it became obvious to me that I couldn't differentiate an isolated femur fracture. And usually when we applied a traction splint, they ended up having injuries that contradicted its use, like dislocation or lower extremity injuries or that sort of thing. So the other thing that comes up about femur fractures is, as you rightly pointed out, they can really swell. You can get a liter of blood in the typical adult thigh compartment. A lot of pre-hospital care providers are tempted to put a tourniquet on a closed femur fracture when they're swollen. And I've actually heard different opinions from the different docs on whether that's appropriate or not. So thoughts from you guys?
Yeah, so I'm not a big fan of traction splints. And my fear is that in polytrauma, it's hard to say, and we talked about this a few minutes ago, is it dislocated? Is it broke? Hard to say without imaging. If it's an isolated femur, i.e. someone has a baseball bat across their thigh, no other injury, and you're 100% convinced, and you're not going to be wrong, it's isolated femur, and they're hurting, traction is reasonable. But again, it goes back to how many times this year have y'all put a traction splint on somebody? Yeah, exactly. So for me, I could break one out. I know how to do it, but I'm going to be scratching my head, and it's going to take me a few minutes. So if you're convinced it's isolated femur, traction splint's fine. If you're not convinced, don't do it. Immobilize it, secure it to the backboard, do a whatever you got. That's reasonable. Tourniquets. The only time I put a tourniquet on a closed femur fracture was this patient. It must have lacerated his femoral artery because his leg went from normal size to Popeye in a matter of minutes. And I was thinking profanity in my brain, right? That guy got a tourniquet. Now, was it the appropriate thing to do? I don't know, but I had convincing evidence in my mind that he had acute arterial bleed, and I was putting a tourniquet on that. Now, obviously, it's going to tamponade off when it fills up that thigh, but you can lose a lot of blood there. So I'm not sure about the tourniquet for closed. What's the right answer is I don't know. What do you think? I don't know.
I've personally never considered it. But then again, I've never had to deal with a patient for more than a few minutes, in a hospital setting with a femur fracture.
Yeah.
So I would agree in that if your suspicion for a bad vascular injury is extremely high and they're developing evidence of a massive bleed in a compartment, then sure. But making it a routine use, I think, is probably overkill.
Yeah, I agree. Yeah, this is not routine. This is that exception once in a career. Holy crap, what do I do? Well, I'm going to put it on. Now I'm going to call Met Control. Hey, doc, this is what I got. This is what I did. What do you think? And we may say, nope, don't do it. Take it off. You're a moron. Or it might say, hey, great idea. You just saved a life. You never know, right? It's like marriage. I take that back. Sorry. Hey, a couple of updates. I know we're running short on time. Just a few things to think about. Tourniquet use. My thoughts on tourniquet use on a patient that has multiple penetrating wounds. For example, the dude shot in the belly, shot in the chest, shot in the arm, shot in the leg, and he's unresponsive and symptomatic, critically ill. You look at that guy and you recognize he is in hemorrhagic shock, and you're thinking it's from the chest and the belly. Great, manage that. But at the same time, someone on scene should be throwing a tourniquet on all those extremities, because what we've seen recently is we start hydrating these people up, putting blood in them, and lo and behold, that leg that wasn't bleeding is now got a pumper on it. So do that. We can take it down in the trauma bay. No harm, no foul. Things to remember as well, Cadaver Lab, September 11th, 12th, and 13th. If you want to bring on-duty crews, shoot me a text or email. We can do that easier than going through Eventbrite. If you're looking for us to come out and do EMS Challenge at your location, we have dates in January and February still open. We're full up until then. And then the other big thing I wanted to mention is MDAC for the BREMS region is September 23rd. And the reason I say that afternoon, I'm holding the first regional QI process. So what we're going to do is I'm going to invite all agencies to come out, bring your QI plan, your EMS officer, bring a few crews. We're going to sit down and look at the paperwork, see how you're doing those things, and make sure you're following the plan that you sent to the state. This is optional for everyone. However, if you're an agency that is using UAB, ER group is your medical control, it is not optional. Someone needs to be there. This is not a bashing session. This is a session for us to look at documentation to see what is good, what is bad, to talk about the things that I see as the regional director that we can improve. The state made the QI process part of your application. So now we're going to act upon that process that you submitted as an agency. So September 23rd, that afternoon. So that's all I got.
Very good. We've got a lot of exciting stuff happen. Where's our next event, Dr. Ferguson? At Brims. All right. Well, thanks everybody for attending on purpose. I hope you attended on purpose and not by accident. And thanks for everybody joining us online. Please remember to fill out an attendance form, even if you don't need the CEUs. It's a way for us to track the function of our program and to get your valuable feedback. There's a link to the attendance form in the chat online. If you're in person, we'll get the QR code up for you. If all that fails, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link. And that's all we have for today. Thanks for attending. See you next time.